doctor, working with Dr. Morgan, who's just here. It's interesting, I'm following him because he's kind of the grandfather of stroke in this state. He really changed stroke care in this state. He's treated a lot of stroke patients, and he's changed the way stroke care is delivered in Oklahoma all across, not just for Integris. Should we wait on Dr. McNeil to get started, or no? Is everybody here except I know she stepped out? So today we're going to talk about stroke and go through that. The first thing, the epidemiology of it. It's the second leading cause of death worldwide. In the U.S., it's the fifth leading cause of death. But the most important thing up there to me is it's the number one cause of adult disability. So, it causes people to be paralyzed, not be able to talk and say what they want. And that's why recognizing stroke acutely and treating it is so important. There's about 800,000 strokes a year in the United States. Oklahoma, we're part of the stroke belt. We don't have the highest rate of stroke, but we're one of the highest rate of stroke, and then we're the fourth highest rate of death due to stroke in the United States. They're not exactly sure why that area of the country, beyond lifestyle and the way we live, has a high stroke rate. Because even if people that were born here move out of this area, they actually still have that increased stroke risk. So these are the different types of stroke. What's the definition of a stroke? A stroke is a sudden brain dysfunction related to a blood vessel abnormality. So either a clot plugs the blood vessel up, so it's kind of like a pipe, and you can't get blood flow to that area of the brain tissue, and it leads to the stroke symptoms. So ischemic stroke is obviously more common than hemorrhagic strokes. Hemorrhagic strokes are usually, that are non-traumatic, are usually related to high blood pressure, and then you have subarachnoid hemorrhage, which is related to aneurysm. We'll talk more about each of those. So this is another description of the different types of stroke. Ischemic stroke being the most common, and hemorrhagic stroke. As you can see, an ischemic stroke is going to cause more focal deficits depending on the area of brain affected, where if you have bleeding in the brain, that increases the pressure within the brain, or within the skull, leading to sleepiness and being intunded. TIA is kind of like a stroke warning in the media, or on TV it's commonly called a mini stroke. I don't like that term, but TIA means transient ischemic attack, and so it's a transient episode of neurological dysfunction caused by focal cerebral ischemia. So it should fit with a specific vascular territory. If you're going to call something a TIA, you should be able to say what blood vessel was being affected. Time used to be a factor in the definition of TIA. It no longer is, mainly because of neuroimaging. MRI primarily has gotten so good at identifying stroke that you can have symptoms for 10 or 15 minutes and it will show up on an MRI scan. But typically they'll last about 5 to 20 minutes. And then that patient, if they have a TIA, and a lot of them don't present for medical care because their symptoms will last 3 minutes, a few minutes, and they'll just brush it off. But they're at increased risk to have a stroke within the next 48 hours and then also within that next 3 months. So TIA is actually a medical emergency, and those patients get admitted to the hospital and worked up just as if someone who had had a stroke would. These are the different types of strokes. So basically, when a patient has a stroke, there's a lot of different causes for them to have a blood clot that goes to an area of the brain. There's if somebody has blockage in their carotid artery, that's called large artery atherosclerosis. People talk about stroke, that's the first thing people wonder about, oh, is their carotid artery blocked? Cardioembolic strokes, AFib is the most common cardioembolic stroke. It's a very common cause of stroke. Small vessel is mainly due to vascular risk factors, high blood pressure primarily, smoking, diabetes, aging. Those are called lacunar strokes. Stroke of other determined etiology, meaning that it's not caused by one of those three above. So that can be a carotid dissection, which is a tear in the inner lining of the artery, or a venous stroke, one of the veins gets plugged up with a clot. And then there's stroke of undetermined etiology, which is also called a cryptogenic stroke, meaning after extensive workup, extensive testing, we don't know why that patient had a stroke. Beyond saying they maybe have a little bit of high blood pressure, but we don't know the actual cause. Lacunar strokes, again, these are the tiny arteries, the penetrating arteries that supply the deep areas of the brain, that white matter, the basal ganglia, if you remember from neuroanatomy, those areas. And they cause specific syndromes. I had a table, but it didn't make it on this lecture, of the different types of lacunar stroke syndromes. Usually they'll have pure motor hemiparesis because it's only involving the motor tract, so they'll be weak in their face, arm, and leg. Or they'll have just numbness because they had a stroke to the thalamus. And there's different variants of that. So getting into hemorrhagic stroke, intracerebral hemorrhage and subarachnoid hemorrhage. Hemorrhagic stroke is highly fatal. It's very dangerous. And we don't have the best treatments for hemorrhagic stroke at this time, to be honest. But the mortality at 1 year is about 55%. Common causes of hemorrhagic stroke, hypertension is by far the most common cause. Amyloid angiopathy is a syndrome of where the protein plaques, amyloid plaques, get deposited in the blood vessel walls and cause what we call microbleeds, and then they can cause a big hemorrhage as well. Usually it's associated with a dementia. Coagulopathies, meaning that the patient is usually on Coumadin or other blood thinners, is a risk for those. Vascular malformations, and then illicit drug use. And then another thing that's not on there is an ischemic stroke with secondary hemorrhagic transformation. It's another type of cerebral hemorrhage. Usually they'll have headache because it's irritating the meninges, which surround the brain, where all the nerves are, because the brain itself doesn't have any sensation for pain. They'll have vomiting due to the increased intracranial pressure. Their level of consciousness will be decreased, and they'll have some right-sided weakness. They won't be able to move their right side or their left side. They won't be able to talk right. Their speech will be slurred. They may have visual problems off to one side, depending on where the hemorrhage is at. Sometimes they can have a seizure at the onset, and they usually will have significant high blood pressure. And that's what you target treatment on, is lowering that blood pressure. And the goal blood pressure in someone that has intracerebral hemorrhage in the hospital is systolic blood pressure less than 140. That's probably on another slide. Subarachnoid hemorrhage. This presents as a sudden onset of the worst headache of my life. They may lose consciousness briefly with it. It can happen to young. It can happen to old. As you age, there's increased risk for developing aneurysms. Most subarachnoid hemorrhages are due to an aneurysm, which is an outpouching of the blood vessel wall, a weakening in the blood vessel wall. And the CT scan initially can be negative, though in the modern era, unless your CT scanner is from the 70s, that rate is actually much lower. But that's the common test question. It can be negative up to 2 to 4% of patients. The mortality for subarachnoid hemorrhage is very high. So recognizing a stroke is mainly when they come into an ER, is getting a targeted history and doing a focused neurological exam. In stroke, the symptoms are going to be abrupt, meaning they're going to be sudden. That patient's going to have a sudden change. One moment they were normal, the next moment they're abnormal. And then risk factors, do they have any stroke risk factors? You want to try and figure that out if you can. So did the paramedics grab the medicines that they take at home? You can figure out their risk factors based on the medicines they're on. Do they have diabetes, high blood pressure, heart disease, high cholesterol? Do they have an irregular heart rhythm? Do they smoke? And again, the clinical pearl here is abrupt onset, rapid onset, because there's a lot of stroke mimics out there. But usually, if you get a good history, you can figure that out. So the neurological exam, you'll check mental status, you'll check their motor function, visual fields, the sensory exam, coordination, and then do you see any abnormalities that would fit a vascular territory or a hemisphere? You know, if somebody has a stroke in the left hemisphere, they're going to be weak on the right. They're usually, if it's a large stroke, they're going to have aphasia. Which hemisphere controls language?
We get that tomorrow.
It's the left hemisphere. So, and then, so level of consciousness, are they alert? Or are they lethargic, obtunded, stuporous, or are they in a coma where they're non-responsive at all? Mainly you want to describe what you see rather than use these terms. It's better to describe what you see when you're seeing a patient. Do they answer questions? Do they respond appropriately? Usually with acute ischemic stroke, you're not going to see people lose consciousness. It's not 0%, but that's a rare presentation of stroke. Usually they're going to have focal findings, meaning an area of a brain. A specific lobe of the brain is going to be injured, and depending on what that lobe controls, are the symptoms that they will have. So if it affects the left frontal lobe, they're not going to be able to say what they want. That's called aphasia. Okay? So can they repeat, understand, can they name objects? How is their language? And that's a key point. A lot of ER residents at our hospital struggle with aphasia and dysarthria, but they're very different. You know, aphasia is very localizing. Dysarthria is not. Dysarthria is very nonspecific. Dysarthria is articulation. Aphasia is language. Orientation. Do they know where they are? Do they know the year? Do they know who the president is? And so for motor function, you're going to look at their face. Is their face symmetric? I'm sure y'all seen stroke advertisements of the lady on there with a facial droop. You ask the patient to smile and see if there's any asymmetry. And mainly you want to look at what's called the nasolabial fold. And sometimes they'll have some subtle flattening on one side compared to the other. And then you want to check, can they hold their arms in the air and not drift down? Okay? If they drift down, that usually means that arm is weak. And that's called a pronator drift when you do it like this and they kind of pronate in. Visual fields. Have y'all gone over the neural exam? Okay. So visual fields, we're not looking for you to wiggle your fingers and see how well you do. Can I use you as an example? So look at my nose. How many fingers do you see? How many? Good. How many? How many? How many? Good. So you can check it real quickly. You don't need to stand behind them and wiggle your hands or do anything like that. So, and if somebody's non-responsive or in a coma or not attentive to you, then what you can do is you can threaten their visual field. Or sometimes the trick is if you have a lot of money when you're working as a PA, you can grab your $100 bill and hold it in the air to one side and see if they look over at it. Kind of a good way to work. And then you want to see, so if somebody's having a large stroke on the left side of their brain, their eyes, if it involves the frontal lobe, where your frontal eye fields are, their eyes will be forced over, they'll be looking at the stroke, so they'll be looking over at the left side. Okay? That area of the brain has been damaged, and the left frontal eye fields push the eyes over to the right, right pushes them over to the left. So if you damage that area, then that right is online, and the left is not. So they'll be looking at the stroke, just remember that, okay? And that usually is a predictor of a very large stroke, actually, and it's important to recognize that and tell, if you're in an ER, tell the neurologist on the phone that they won't look over to the right. They seem to want to always look over to the left. It's very localizing. And then sensory is just touching for sensation. It's sometimes helpful, but it's still subjective and you're still relying on the patient to tell you if they can feel or not. So if somebody's having a stroke, usually they'll have loss of sensation on one side of their body, either in the face and the arm, or face, arm, and leg. And you can use something sharp to check, or you can just touch lightly when it's in regards to evaluating a patient with a suspected stroke. Coordination is, you're looking at how coordinated they are. The key here is if they have weakness, then you have to relate, okay, is that coordination problem due to the weakness, or is it actually that I think this person is having a stroke in the cerebellum, which is the balance center, because that's what this was meant to check. And so how you check that is you do what's called finger to nose. You have them touch your finger, touch their nose, or touch their forehead, either one, and you look, and if they're having a cerebellar stroke, then they'll go past your finger or not to it. They won't, like when you tell them to touch your nose, they'll touch over here. I mean, that's just them being goofy. And then bidirectional nystagmus, meaning the fast phase of this nystagmus changes directions when they look right and left. If they have decreased level of consciousness or poorly responsive, you want to see if they have a gaze preference like we talked about. Are they looking to the right or to the left? Are their eyes disconjugate, meaning one eye is all the way over to the right and the left eye is looking forward? That would make you suspicious for a brainstem problem, something that controls the cranial nerves, if they have a disconjugate gaze. You can check for what's called doll's eyes, where you roll their head around and see if their eyes fall with their head. You look at the pupils, you pinch on the inside of their arm or do some kind of painful response in all the extremities to see if they'll move. And then you can check for what's called a Babinski. You guys know what a Babinski is? One of Dr. Morgan's phrases is a Babinski is always smarter than a neurologist. So, this is the NIH stroke scale. This is an exam that's in that little booklet I gave you. This is a standardized exam to do when you suspect a stroke. In a bigger hospital, usually nurses actually are trained to do it. But if you're in Podunk, Oklahoma, you're probably going to be the only person that knows how to do this. But I'll let you look through that in the book. Again, as we talked earlier, a stroke is usually sudden in onset, and it's maximal at its onset, meaning it's the worst. The symptoms are the worst. And the signs should fit within a specific vascular territory. Again, if it's on the left side of the brain, trouble talking, weak on the right side. If it's on the right side of the brain, they may not even know they're having a stroke because they'll be neglectful of that side. It's just a slide isolating the major stroke syndromes, the left hemispheric syndromes, right hemispheric syndromes, intracerebral hemorrhage, cerebellar, and brainstem. So hemispheric, they'll be the right side of the brain controls the left side of the body. So if they have a stroke to the right side of the brain, they'll be weak on the left. They'll be looking over towards the right, and you'll ask them what's wrong, and they'll say nothing. They won't even know that they're having a stroke. And that's what neglect, or anosognosia is a fancy term for it. And then if they're having a left-sided stroke, if it's in the front part, they won't be able to say what they want to say, and they'll be frustrated and angry. And if they had a stroke in the back part, where it controls our understanding of language, then they'll be just talking, and you won't know what they're trying to tell you, but they won't know that they have a problem. But they'll sound like they're speaking a different language. Brainstem, usually they'll have a ipsilateral cranial nerve deficit, so they'll be numb on their left face. What cranial nerve would cause numbness on the left face?
Trigeminal.
5. Okay, and then they'll be weak or numb on the right side of their body, so on the opposite side. Or they'll have a third nerve palsy on the left, so their eye would be down and out, pupil doesn't work, and they'll be clumsy on their right side. Okay? So brainstem stroke, that's a common board question, is crossed findings, meaning they have a cranial nerve finding on one side, on the ipsilateral side of the stroke lesion, and then on the contralateral body. Cerebellar stroke. Now this is really important because cerebellar stroke is one of these strokes that it's hard for people to recognize because it's sudden onset inability to walk. If you're going to remember anything about a cerebellar stroke, that's what you should remember. Sudden onset of inability to walk. Because it's our coordination center. They're not going to have a paralysis. They'll probably have a little bit of clumsiness depending on which area of the cerebellum is being affected. But almost all of them won't be able to walk. Hemorrhage, as we've talked about multiple times, they'll have headache due to the increased intracranial pressure, nausea, vomiting, and decreased level of consciousness. With intracerebral hemorrhage, they'll have focal neurological abnormalities. Subarachnoid hemorrhage is a sudden onset of a headache, stiffness of the neck, and they won't be able to tolerate the light. Kind of like meningitis, except meningitis will usually have fever and an elevated white count, okay? Because it's irritating the meninges. So it's in the subarachnoid space. And what's the cause of most subarachnoid hemorrhages? Aneurysm. Yeah. Here's a case, a 62-year-old female with an unremarkable past medical history presented to the emergency room at noon following sudden onset of left-sided weakness. Exam on arrival revealed a left hemiparesis, left hemisensory loss with neglect, left hemianopsia, and a right gaze preference. So where's her stroke? Which hemisphere?
Right.
Right, good. There you go. So what do you do when you've discovered that they've had a stroke and you decide what the treatment is? If they present within that golden window, meaning within 4.5 hours of stroke symptom onset, then IVTPA can be administered. That's the clot busting medicine. It's on your little thing. It's Activase. They made these booklets because they want you to use their drug. But it does work, and it's used to be, up until a couple of years ago, really the only treatment we had for acute strokes. Now we have endovascular therapy where a special kind of radiologist can actually go in the groin and thread a catheter up and do what's called clot retrieval. But there's only certain strokes that they can do that for. Another thing on IVTPA, well, we'll talk about it more here. And then the medical management, so the acute care of the patient. So stroke is a medical emergency. Time lost equals brain loss. Over 2 million neurons are lost for every minute treatment is delayed. So you have to react very quickly. And you try to get them, if they're a candidate for the IVTPA, you try to get them that treatment within an hour of them arriving to your emergency room. So the penumbra, that's the area of the brain that you're trying to save. So the black part on there is the core of the infarct. The penumbra is the area of the red outside that, and that's the area. So they're having this big stroke, they're weak on their right side, they can't talk, and you're hoping to improve that some and reduce disability. This is just discussing a penumbra as the reversible area of ischemia. Things that damage the penumbra are hypoperfusion, meaning low blood pressure. So stroke patients are going to come in, their blood pressure is going to be high. That's the brain's reaction to the stroke itself. And so you actually let their blood pressure run high. If they're not a candidate for the TPA, you actually let it for the first 24 hours run up to 220 over 120, which scares a lot of people, but it's okay. That's the body's reaction. And if they're going to get TPA, then you want it below 185 over 105. Those are either in this booklet or in the slides. And then hyperglycemia. So you want to get glycemic control. You want to treat fever, and then you want to treat seizures. So this is the emergency management of a stroke. As you would approach any other critically ill patient. Now actually CABs, but the ABCs. So if they need to be intubated, it's rare that an ischemic stroke needs to be intubated, but not impossible. You want to monitor their vital signs, look at their cardiac rhythm, meaning they're on telemetry, getting an EKG, check their oxygen saturations, IV fluids. You want to make them as euvolemic as possible. And then you do a rapid neurological exam. And then the diagnostic studies. So the things you want to check is, the first thing you always check is a finger stick blood sugar. Okay, check their glucose. Because hypoglycemia is one of the mimics of stroke. So you want to treat that quickly. That's what paramedics, that's the first thing they do when they get to the scene. So you want to check blood chemistries, you want to get a CT scan of the head. So now when patients come in for what we call a code stroke, EMS calls our hospital ahead of time to let us know that they're bringing in a stroke, the ER, and they go straight to the CT scan. Usually EMS can get an IVs in, and they'll actually even draw the blood out so that the nurses can just grab it and send it to the lab. And then you want to get an EKG, and you check the CBC and INR, check their platelet counts. But the only thing you have to wait on except is the CT scan and the finger stick blood sugar to decide on TPA. And then the rest of it is historical, based on is there any contraindications to IV TPA. So you don't wait for all this stuff to come back before you call the neurologist, because like we said, time lost is brain lost, so you treat them quickly. CT scan is a rapid test. We would love to get MRIs on all the patients as they come in, but it just takes too long. CT scan takes a couple of minutes to run. And we can't give anyone TPA without getting this, so that's why that's the first thing they go to when they come to our ER door. And the main reason why you want a CT scan is to rule out that they've had a hemorrhagic stroke. Okay, because you obviously don't want to give a clot-busting medicine or a blood-thinning medicine to someone that's already bleeding in their brain. And you just need a non-contrast CT scan. CT scan, this is talking about the 50 shades of gray. So, bone in contrast show up bright white as well as blood on a CT scan, where soft tissues show up more gray color, and there's different densities based on that tissue. So bone has the highest density. So hyperdense tissues appear light or very bright on a CT scan. I have a few samples here. So, and then hypodense areas are dark. So CSF is black because it's basically water. And it takes about 6, maybe even up to 24 hours for a stroke to show up on a CAT scan. Whereas I told you earlier, MRI takes about, some people say 10 minutes, but usually 30 minutes. So CT scan, the advantage, it's fast. Almost every hospital has one, even though there are hospitals in Oklahoma that do not. And then because of weight, we've had patients sent to us to get a CAT scan because the outlying hospital, the patient weighed 500 pounds and couldn't get on their CAT scanner. So that, we run into that sometimes, which is always complex. So, it's very sensitive for hemorrhage. The disadvantages is it's not as good at evaluating the posterior fossa because, again, your skull is actually thickest in the back part, so it's having to penetrate that thick skull. And it doesn't identify early ischemic changes, so those are the disadvantages. And also remember, if somebody's there for within an hour of stroke symptoms, their CT is going to be normal. So that's what we're hoping for. You know, it takes 6 to 24 hours for a stroke to show up on a CAT scan. So this year, won't name names, but you know, I ran into a patient that actually was a lawyer that got sent home by a new graduate from the ER because their CT scan was normal. And then he called his doctor and he sent him down to us. But so just remember that a normal CT does not rule out a stroke. This is a very large left hemispheric stroke. You see the area of damage, how it's very hypodense, where that right hemisphere looks very healthy. Here's a right basal ganglia stroke. See that hypodense area in the head of the caudate and the basal ganglia, the internal capsule there. This is an early infarct. See, it's not as obvious as that stroke earlier. And then see how that stroke is already developing and it's pushing over left to right. So this is an early stroke. This is what that stroke would look like probably 6, 7, 8 hours. Okay, so see, it's just subtle levels of gray. And they have what we call sulcal effacement. Okay, the sulcus are the little curly parts in the brain. And see how it's all flattened on the left side. Oh, and by the way, when you're looking at a CAT scan, I guess I should clarify this, I don't know if you know this. You're looking at it as like you're looking at a person lying in front of you. So, you know, that's the left side and that's the right side of their brain. Does that make sense? Intracerebral hemorrhage is a basal ganglia hemorrhage. You know, most hypertensive hemorrhages are going to be subcortical, meaning involving the white matter in the basal ganglia, or in the cerebellum, or in the pons. Where those tiny little penetrating blood vessels are, is where those are the blood vessels that are usually the ones that rupture and bleed. Those same arteries that also cause lacunar strokes. This is what we call a lobar hemorrhage. This is where you start to wonder, depending on their age and everything, could they have that amyloid angiopathy. So this is intracerebral hemorrhage at 2 hours and then 6.5 hours. So that hematoma obviously expanded quite a bit. And then they have blood in the ventricles. Do you see that? Ventricles are the fluid-filled sacs. Right here. So that's not a good prognostic finding there. And then the growth of the hemorrhage, and now there's right to left shift. So the pressure in that skull is increased. So what else would you expect to find on this patient's exam? If they have a big hemorrhage on the, you know, they're non-responsive, let's say they're already intubated, non-responsive. What else would you expect? If they're in the ICU, they'd probably have their right side strapped down to not pull on tubes, and they wouldn't have any restraints on the left side, right? Because why is that?
They can't move it anymore.
Yeah, they're paralyzed. So usually in the ICU setting, when you walk in the room, a patient with a stroke will just be strapped down on the right side. Okay? Restraints on the right side of their body. This is what a subarachnoid hemorrhage looks like. See how very different this looks? It's kind of layering the meninges. You can kind of tell it's sitting on top of the brain, not in the parenchyma. If you find an aneurysm, usually you'll consult neurosurgery and a neurointerventionalist who will, they'll either get a clipping of that aneurysm or coiling of it when they're stable enough to do so. Blood pressure control, usually less than 140, but it actually differs for every patient. You really want to maintain euvolemia, meaning you want to keep them well hydrated, but not overhydrated. And then Nematop is a calcium channel blocker that helps with vasospasm. Because vasospasm can be quite fatal to a patient with subarachnoid hemorrhage, because it can cause further stroke and damage. MRI uses a magnet. It gives very good soft tissue exams, gives us a very nice picture of the brain. The low signal intensity lesions are dark and high signal intensity lesions are bright. So advantages of MRI, it doesn't involve radiation. It's very sensitive to early ischemic changes, and you get a better visualization of the entire brain. Some disadvantages to it is, I feel like everybody in Oklahoma is claustrophobic. They have metallic implants or pacemakers, and then if patients move, it can cause artifact. So some areas that may look abnormal, but they're really not. And an MRI of the brain takes about 20 to 30 minutes. A non-contrast MRI of the brain takes about 20 to 30 minutes. So this is what an acute ischemic stroke looks like on an MRI scan. Diffusion-weighted imaging is the most sensitive modality for MRI. And when you order an MRI of the brain, your hospital will have a protocol of what images they obtain, but they're almost always going to obtain these. So this is DWI, so this, when it's bright like that and dark on the ADC, we call that restricted diffusion, and it has to do with how the hydrogen ions move within that tissue. And then the flare, it's that hyper-intense area. And then these changes here are what we call white matter changes. And this is hyper-intense white matter. This is usually due to high blood pressure and poorly controlled vascular risk throughout a patient's life. This is called gradient echo imaging. So this black spot right here is blood. So it's looking at hemosiderin. So hemosiderin is in blood. So it picks up hemosiderin stains. This is how we find those microbleeds that I talked about that can be related to hypertension or amyloid angiopathy. And that could even be what we call a cavernoma or a vascular malformation. So that's another, just a different view of it, a coronal view of a small hemorrhage or blood product. So this is medical management of intracerebral hemorrhage. You want to maintain their oxygen saturation above 94%. You intubate them if they can't protect their airway. Meaning you think they're going to aspirate and eventually become hypoxic. You want to reduce their systolic blood pressure to less than 140. But you do want to also avoid hypotension. So you don't want it to get below 110. You treat any hyperthermia. So give them Tylenol. You don't want to give them NSAIDs because that can worsen the bleeding. Glycemic control. If their INR is elevated because they're on Coumadin therapy, you reverse that with IV vitamin K. The IV version, not the pill, not a pill or injectable, the IV. They don't need steroids. And then you avoid any other complications. Try and avoid DVT, blood clots in their legs as much as possible. You try to avoid pneumonia. So when these patients come in, you don't just let them drink water. You actually have a speech therapist come in and evaluate them and see if they're safe to swallow. Because a lot of times when people have a stroke, their swallowing will be affected. And if they swallow and aspirate and they get pneumonia, that increases the mortality of the stroke patient. Acute ischemic stroke intervention, so you want to optimize the cerebral perfusion to the area being damaged. So again, those things we talked about, oxygen, temperature, blood sugar control, and then you allow permissive hypertension. IV TPA and endovascular therapy are what we can do to restore blood flow, so trying to get the clot. Again, for IV TPA, they need to present within 4.5 hours for most patients, and the FDA has it only approved up to 3 hours, but the American Stroke Association, American Heart Association, and everyone else says up to 4.5. Endovascular therapy. Again, do not treat elevated blood pressure unless it exceeds the goals. So if you're gonna, and then also you want to avoid hypoglycemia. You don't add glucose to their IV fluids unless they're hypoglycemic. You don't want the head of the bed elevated straight up. You want them down 0 to 15 degrees. That allows for more perfusion. You supplement their oxygen if needed. Keep it greater than 94. You give them Tylenol for fevers. Storing blood flow to TPA. So again, this was the initial trial for TPA back in 1995. And they treated people that presented with less than 3 hours. That's where the 3 hours comes in. So symptomatic hemorrhage. So if you give people a clot-busting medicine and they're having a stroke, that area of brain is susceptible to bleeding because of the breakdown of the blood-brain barrier. And so, strokes in general can bleed, but in people that got TPA, people that didn't get TPA, or got the placebo, there was a 6% increased risk of bleeding. The mortality was reduced with IV TPA at 3 months, 17 to 21%. So TPA is now considered the gold standard of the treatment of acute stroke. It does work better for very large occlusions, so proximal occlusions, right where the ICA is coming up and branches into the MCA and the anterior cerebral artery. If you have a clot there, TPA usually doesn't work as well, but you still give it and you send them somewhere where they can get endovascular. It decreases their disability by 30%. So that's the biggest thing we noticed. And this isn't right away always. TPA is not a magic bullet for strokes. It's really, you see the effects if you look at patients 3 months down the road. So a patient that got TPA versus a patient that didn't, the one that didn't may be in the nursing home, where the patient that got TPA is still able to care for themselves at home. So the TPA, it's the only FDA-approved medication. There's other clot-busting medicines similar to TPA, but you don't want to give those. There's some exclusion criteria. Again, you can give it up to 4.5 hours. The American Heart Association, American Stroke, and your neurologist on call can help you decide for all of those patients. There are some exclusion criteria. Again, you have a narrow window, and the treatment rate in 2011 was only 7%. I don't think that's changed much. 7% and about 30% of strokes present within the time window to get TPA. So there's still a big percentage of patients not being treated. These are the exclusion criteria. I'm not going to go over all of them, but the big ones are if they have active bleeding in the brain, obviously you're not going to give it. If they have active GI bleeding, you're probably not going to give it. If they've had a recent surgery, they've had a lumbar puncture within the past 7 days, you may be hesitant. But some of these are softer exclusions, like platelets less than 100,000, usually would stop me from giving it. And then there's new blood thinners, Eliquis, Xarelto, these things that they can't have had within the past 48 hours. And their INR needs to be less than 1.7, or if it's greater than 1.7. They are excluded from TPA. So this is The New England Journal of Medicine published this in 2015. For endovascular therapy, for going in and getting large clots. There was 5 trials that came through and showed benefit. They've been studying this since IVTPA was discovered in '95, and all the trials have failed up until 2015. So stent retrievers, these are the devices that go in to get the clots. It actually pushes the thrombus against the wall, and the thrombus seeps in. They wait, and then the retriever closes and pulls the thrombus out. These are just some numbers on the trials. I'm not going to go into details on that. For endovascular therapy, they need to be age greater than 18. So if a 17-year-old or 16-year-old came in with a big stroke, I would give them all the treatment I would an 18-year-old. Their NIH stroke scale score needs to be greater than 6, meaning that they're going to need to be having a larger stroke to be a candidate for this, because we can't get to those smaller blood vessels with these devices. So it's going to be a large artery occlusion. So now with stroke, in addition to getting a CT scan of the head, we're getting what's called a CT angiogram usually with that, and that allows us to evaluate these large vessel occlusions. These patients need to be at the hospital with a neurointerventionalist or sometimes a neurosurgeon, depending on where you work, with a needle in the groin at 6 hours. Not that they get to the hospital at 6 hours, they actually have to have the needle in the groin at 6 hours. So usually the ones you're going to treat with TPA are lesions this is where the carotid artery enters the skull, or we have thrombus here, or the M1, or the initial branch of the ACA you may be able to get to. Okay. Sometimes they can get to an M2 branch, but not always. So this is what we call a dense MCA sign. Again, this is the left middle cerebral coming up. You can see how it's hyperdense there. So that's blood clot. And this is the CT angiogram that they got, and that artery is occluded. So over here you see a nice M1. This is the ACA. So this is right, left. This is posterior cerebral. And you just see no more blood flow. And then if you look over here, see all these branches of blood vessels here compared to over here. So there's decreased opacification over here. Okay? All right. Any questions? So there's a second part to the lecture that's mainly just going to go over some case studies with you all. I know I went through that pretty fast, but so any questions?
I was curious, has there ever been a case where if the clot was too big for RTPA, but you couldn't get to it for the endovascular retrieval?
Well, yes. Well, TPA doesn't work 100% of the time.
So what do you do for this?
Yeah, that's all you can do. Is you give the TPA, and then after the TPA, we didn't talk about this, but you'll start them on usually an aspirin or these things. But yeah, the TPA doesn't always break up the clot entirely. And it's not the clot. Your body will break down the clot. The clot is not the problem. It's the lack of blood flow to that area of the brain. So we have the circle of Willis, which allows for collateral flow. So a lot of people have a stroke, and if they have collaterals, they will supply that penumbra. And besides breaking up the clot, we don't know why TPA works so well, because it doesn't always get to the clot, but some people still get better. And it's probably because it opens up those collateral blood vessels and allows more blood flow to that area of the tissue. Because the clot is the problem, but the tissue not receiving the nutrients, the glucose, the oxygen, that's the real issue. That's what you're trying to restore. Did that answer your question? Stroke is very devastating. There's sometimes not things A lot of people I see every day that present 6 hours, 7 hours, 8 hours with a massive stroke. And, you know, there's really not a lot we can do at that point, besides trying to prevent complications. Any other questions? Okay. Well, I think with that, we can take a short break so we can switch over to the slide.